So I'm going to begin by discussing the tendons. And when I discuss the tendons, I'm going to compartmentalize things. So I'm going to discuss the medial tendons, moving on to the lateral tendons. Then we'll talk about the main anterior tendon or the biceps tendon. And then we'll talk about the posterior tendons. I'm going to move on from there to talk about the ligamentous structures of the elbow. And there we're going to address the medial collateral ligamentous complex and then move on to the lateral collateral ligamentous complex. I'm going to touch briefly on ulnar neuropathy. I can't possibly do all of the compressive neuropathies at the elbow in this talk, given the time constraints. I think ulnar neuropathy is most common, so I'm going to talk about that. And then lastly, I'm going to touch on some special injuries in the adolescent athlete. So let's start with the medial tendon. And I like to understand anatomy before I look at pathology. I think it's very important. So in this netter depiction here, we're going to go over the common flexor tendon. We know that it originates from the medial epicondyle, specifically the supracondylar ridge. There are actually three layers of the flexor tendons. There is a superficial layer composed of these tendons denoted here, the pronator teres, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. There's an intermediate layer, which is the flexor digitorum superficialis. And then there's a deep layer, the flexor digitorum profundus. That one doesn't actually originate with the rest of the tendons. Note that I have underlined here the pronator teres, flexor carpi radialis, and palmaris longus, because although it's hard to distinguish them separately, those are the ones that are most commonly involved in injury. Medial epicondylitis, commonly known as golfer's elbow as opposed to tennis elbow laterally. It's really kind of a misnomer. It's seen with many different activities, but I think we see it most frequently in the throwing athlete, and we'll discuss why in a little while. It's an injury of chronic repetitive overuse, so it's microtrauma from chronic repetitive overuse. It's very important both clinically and by imaging to differentiate this from injury to the underlying ligamentous structures. This injury will not be associated with elbow instability. Injury to the medial collateral ligamentous complex will be associated with elbow instability. Also, there's a high degree of associated injury to the ulnar nerve and ulnar neuropathy, which is important to take a look at. If conservative therapy fails, they will go in and surgically debride the diseased tendon segment. Here you can see the arrow denoting a subtle increase to T2 signal on this fluid-weighted sequence at the medial epicondyle and the common origin of the flexor tendon, seen very nicely on the axial images. Here you can see that small pocket of fluid, high signal intensity, interposed right at the origin of the common flexor tendon. That's a partial tear associated with medial epicondylitis. I'm going to make a plea here not to ignore your sagittal images. The sagittals can really be very helpful. Go all the way out medially, especially if you have a fluid-sensitive sequence, and you're going to see it beautifully there, partial detachment of the common flexor tendon. Okay? Just to show you another case, a little more subtle in this particular case on the fluid-sensitive sequence. Again, you can see, much as you would with the medial collateral ligament in the knee, fluid interposed on both sides of this tendon. On the axial, we can see this subtle, tiny pocket of fluid signal intensity at the origin of the common flexor tendons. And again, don't ignore your sagittals, depicted beautifully on your sagittals. I think that's a particularly good imaging plane to look at the flexor and also the extensor tendons. Let's move right on to the extensor tendon. And let's do a little bit of anatomy. We know that the extensor tendons originate from the lateral epicondyle. They are composed of, or the common extensor tendon rather, is composed of the extensor carpi radialis brevis, the extensor carpi ulnaris, the extensor digitorum communis, and the extensor digiti minimi. Of note, the extensor carpi radialis longus originates separately from the common extensor tendon. And note here that I've underlined the extensor carpi radialis brevis because that is really the most critical component and the component that is most commonly injured. So lateral epicondylitis now. This is known as tennis elbow. It's much more common than medial epicondylitis, on the order of 20 to 1. All right, so you're going to see a lot more of these than you're going to see of the medial epicondylitis unless you're taking care of a lot of pitching athletes. Again, this is an injury of chronic overuse and repetitive microtrauma. And when the surgeon gets in there and debrides the diseased tendon segment, what he finds there is something called angiofibroblastic hyperplasia. So what that means to me is you have hyperplastic tissue there that it both has neovascularity and a lot of fibrous scarring. The extensor carpi radialis brevis is the one that's most commonly injured in this complex. And again, here, if conservative therapy fails, they will go in and surgically debride the diseased tendon. So what does it look like on imaging? Well, on MRI, you can see thickening or thinning of the tendon, but I think what you see a little more commonly actually is fluid interposed. I don't know if that red circle is showing up very well here, but fluid interposed here between the extensor carpi radialis longus and the underlying lateral collateral ligament. That's exactly where the extensor carpi radialis brevis should live. Another example here on a T2 weighted sequence, and you can see that subtle fluid signal intensity there. This is associated with lateral epicondylitis. Another example here on a gradient recall sequence, you can see how there's signal hyperintensity here right in between the extensor carpi radialis longus, which inserts a little or originates a little more proximally, and the lateral capsule here. Now, if this disease process progresses, it can have implications, other implications and other imaging findings. If it can start in the extensor carpi radialis brevis and it can extend more superficially, disrupting the origin of the extensor carpi radialis longus as well. This particular image here also depicts a commonly associated finding with severe lateral epicondylitis, which is underlying bony changes. So you can see those images, those findings here. You can also see it beautifully depicted in the axial plane here. So the bony changes here, marrow edema, and focal fluid here with partial disruption of the common extensor tendon. What about if it goes the other way? This has more clinical implications for the patient. So instead of going just superficially, now the process extends deep into the lateral joint capsule and disrupts the lateral collateral ligament. This patient is going to present in addition with lateral instability of the elbow. This has more clinical implications for this patient, okay? Seen very nicely here on the fluid-sensitive sequence. The lateral collateral ligament here is disrupted. So that can be part of the natural progression of lateral epicondylitis if unchecked. This last case also depicts an interesting imaging finding, which you can see sometimes on plain film. If you look at the lateral margin of the joint here, you're going to note this small area of focal signal abnormality, and you look at the signal intensity there, and it is similar to signal intensity with the adjacent marrow, okay? So if we do a gradient recalled image, we see a little bit of blooming in that area. And now if we were to go back and look at our plain film, and I hope this is going to project for you guys, if you look and you take a close look, there's a very subtle area of calcification here. So in the chronically diseased tendons, you can get heterotopic calcification and ossification. That can be a tip to lateral tendinous injury. Let's move on to the anterior compartment and the biceps tendon. Let's do some pertinent anatomy here. We know that the biceps tendon inserts on the radial tuberosity as depicted here. We also know that the distal biceps tendon has no tendon sheath, okay, much like the distal Achilles tendon. There is, however, a potential bursa there, the bicipital radial bursa, which can fill with fluid in pathologic states. One other thing that is somewhat difficult to identify, but once you start looking at it on enough images, you'll see that you can identify it on a fair number of studies, is this structure here, which is the bicipital aponeurosis or lacertus fibrosus. That is a fibrous extension which comes off of the distal biceps tendon and arches back, merging with the fascia over the pronator flexor group, okay? What's the significance of this structure? Well, this is what helps tether the distal biceps tendon in place. So if you have a very distal biceps tendon injury, but this is intact, it won't retract too far up into the arm. So it's important to tell the surgeon about that. What do we know about biceps tendon injury? First of all, proximal injury is much more common than distal injury. So you're going to see a lot more biceps tendon injuries at the level of the shoulder. If you do have distal injury, complete tears are much more common than partial tears. Now, this may be partially because of our insufficient imaging in the past. We were seeing more and more partial tears, so the ratio may not be as drastic as we thought it was. The mechanism is felt to be a sudden eccentric contraction. The common example given is a biceps curl where you have resistance against flexion, and you get eccentric contraction and a tear. Now, it's important to remember that when you pronate your forearm, that you can bring that radial tuberosity and the distal biceps tendon into that space between the radius and the ulna. So that's a form of impingement syndrome that you can have. So activities that involve common pronation in their mechanism can lead to chronic attritional wear, and you can get an acute on chronic injury. The Popeye sign is something that they see clinically. Our imaging correlate would be a balled up proximal muscle the patient presents in the office with this very large biceps tendon. It has nothing to do with lifting weights, it has to do with retraction. What does it look like on MRI? Well, first of all, we want to let our surgeons know do we have a complete or a partial injury to the distal biceps tendon. As I said before, with advanced imaging, we're seeing more and more of these partial tears. So if you look at this distal biceps tendon here, you can see that it looks diseased. It's thickened and it has increased intrasubstance signal. Here on this other example, again, you see increased signal on this fluid-sensitive sequence in the distal biceps tendon. It is not completely ruptured, but it is obviously pathologic. And you can see associated large fluid collection in the bicipital-radial bursa. That's as opposed to the complete tendon injury, where you can see the disrupted margins of the tendon, and this is the area of the bicipital-radial bursa that's filled with this complex combination of edema and hemorrhage. You want to try to look more proximally to see if you can see a more normal looking distal tendon to let your surgeons know how far proximally did this retract. Your long axis images may be of utility in defining the proximal retraction. Here in this example, we can see more normal appearing tendon, and when we image slightly more distally, all we see is hemorrhage and edema in that bicipital radial bursa. It's important to tell your surgeons where you think the proximal biceps tendon is retracted to. In this case, we didn't even see it on this imaging study. All we saw here was fluid filling the tendon sheath. When you went to an axial sequence higher up in the arm at mid-humeral level, you can see this balled up retracted myotendinous junction. That's important to let your surgeons know. It will affect their surgery. Now, it is possible sometimes to see bony changes, and I love this case because one of the senior radiologists at NYU spotted this finding in the radial tuberosity. I would have gone right by it about 1,000,000 times, called up the clinician, and what followed was an MRI. On MRI, you can see the equivalent here on MRI of that cystic change at the radial tuberosity. You don't see a nice biceps tendon here. You see fluid in that area, and when we looked on other axial images, there you can see the completely disrupted and diseased biceps tendon. So bony changes can lead you in that direction. It's important to look for the Lacertus fibrosis. I don't have a good example of imaging the Lacertus fibrosis in the pathologic state. Let's move on to the triceps tendon in the posterior compartment. This is the least frequently injured tendon in the body. When it does get injured, it is at the level of the tendo-osseous junction or the insertion on the olecranon. The common mechanism, as with many injuries to the upper extremity, is a fall on an outstretched hand. And there are certain patients who may be predisposed by metabolic derangements, i.e. renal osteodystrophy, steroids, rheumatoid arthritis. In this particular case, you can see complete disruption of the distal tendon. It's kind of intuitive. You see exactly where the tendon is retracted to. On the fluid-sensitive sequence, you can see a fluid-filled gap and the proximally retracted tendon. Of note, on plain film imaging, sometimes you'll see, and this is you would see this on the plain film, but I'm showing you the MR example, you can see a avulsion of the insertion here, and you can see this flake of bone that's been pulled off with the diseased tendon, and you can actually see the donor site here. I just want to make a quick note here that Dr. Schweitzer likes to emphasize that you can get enthesopathic change at the triceps tendon insertion as well, although I don't have a good example of it here, and that can be very symptomatic. He gives the example of a professional athlete that he took care of, where he said all you saw was a little enthesopathic bone production, and it was essentially a career-ending injury. Let's move on to the ligaments. We've got to spend a little bit of time of anatomy here on the medial collateral ligamentous complex because it's a little bit complex. First of all, we're going to break it down into bundles, okay? So there is an anterior bundle depicted here. There is a more fan-shaped posterior bundle depicted here. And then there's this transverse bundle, which really is functionally insignificant. It just goes from the distal insertion of the posterior bundle to the distal insertion of the anterior bundle. Of these three bundles, the anterior bundle is felt to be the primary stabilizer, and it is the one that you are going to see as a medial collateral ligament in the extended position because it's taught an extension. It goes from the anterior inferior surface of the medial epicondyle to the sublime tubercle on the coronoid process. Now, if we haven't complicated things enough, we take that anterior bundle and we split it up into anterior and posterior bands. This is not a distinction that you're going to be able to make on imaging. Essentially, the ventral 50% is the anterior band, the posterior 50% is the posterior band, but you will see this in the surgical literature. It's important to remember that both the common flexor tendon origin is intimately associated with the medial collateral ligamentous complex, as well as the ulnar nerve. The ulnar nerve is going to pass here through the cubital tunnel. Part of the floor of the cubital tunnel is going to be formed by both the posterior and transverse bundles of the medial collateral ligament. So pathology in one of these structures can result in pathology in another one of those structures. That's important to keep in mind. Particularly prone to MCL injury is the throwing athlete. It's a chronic overuse injury, and it occurs because of repetitive valgus stress felt to be exaggerated in the late cocking or early acceleration phase of the pitching motion. That's depicted here. You can see that this is an unnatural position for the elbow. We're cranking open the medial joint line. We're placing a lot of tension there and stress on the medial ligamentous structures. We're closing down and impacting the lateral compartment. Okay? I just want to show you another form of impingement that you can get in these pictures as well, and I'm going to illustrate it with a case to follow. It's called posterior medial impingement. What happens here in this illustration, this is the radial side, this is the ulnar side. When you crank open that medial joint line, you're bumping the adjoining margins of the olecranon and the olecranon fossa. Over time, that results in cartilage wear. It results in synovitis and bony debris there, and that can lead to impingement in the position of extension. I will show you a nice example of that. The surgery for MCL injury has come to carry Tommy John's name. He's the first pitcher who underwent this surgery. I believe it was Frank Jobe on the West Coast who did the surgery. Most commonly, they reconstruct the MCL using the palmaris longus tendon, and there is a high degree of associated ulnar nerve injury, so commonly they'll do an ulnar nerve transposition. What does MCL injury look like on MRI? Well, again, we want to try to distinguish between partial or complete tears. In this example here, you can see thickening of this tendon, this ligamentous segment here proximally, and increased intrasubstance signal. This is the imaging correlate of what some people call plastic deformation or remodeling, chronic remodeling of the MCL, which you can see in pictures commonly. This is the corresponding gradient recall sequence here, and you can see that there's abnormal signal intensity in that MCL. This is a partial tear, probably on a chronic basis. This patient presented with more acute symptoms. Again, look at the nice dark signal in the radial collateral ligament on the lateral side. You can see signal isointense to muscle in the medial collateral ligament. That's not normal. When you look at the fluid sensitive sequence here, you can see high signal intensity in the MCL, surrounding edema and bony changes in the medial compartment. This was probably more of an acute injury, i.e. some sort of sprain. Now, it's pretty intuitive what a complete tear is. You're going to see focal disruption of the MCL, presumably a fluid-filled gap. You won't get a lot of retraction, so you really want to see that gap. It's illustrated nicely here on this fluid-sensitive sequence, as well as here on the gradient recalled sequence. This is a complete tear of your MCL. Those of you doing arthrography may see this injury, which was popularized in the literature recently, which is a partial detachment of the distal ulnar attachment of the MCL. And the name given to this is the T sign because you can see this T on its side defining the pockets of fluid that you see at arthrography. That's partial detachment of the distal MCL. All right, let's take a look at some associated changes you get in these patients with MCL injury. This is a professional picture here, and his case beautifully illustrates all of the associated changes. This is actually post-Tommy John surgery, so this is a graft. We're not going to pay attention to that. We're past the MCL injury. What I want you to see here is the associated changes. So look for these traction osteophytes along the medial joint margin. That's from cranking open that medial joint every time you pitch and putting stress there. This particular pitcher came in with acute exacerbation of pain, and he had associated severe medial epicondylitis with partial tearing of the common flexor origin here. So now he's showing us at least two associated signs. This is a beautiful illustration here, I think, of what I was telling you about before, that posterior medial impingement. Look at, this is the humeral ulnar joint here. Look at the cartilage intact laterally, and then look at the absence of cartilage posterior medially, large osteophytes back there. Also very nicely depicted on the fluid sensitive sequence. Fluid where you should have cartilage. This is because every time you crank open that joint line, you're bumping this against this, cartilage wear, osteophytes, marrow edema. What that results in here on the sagittal image is this ball of scar tissue, synovitis, and debris posterior superiorly, so this patient is presumably going to have limited extension. Now, with all of these changes posterior medially, it's no wonder that the ulnar nerve won't really have much room to breathe. So in this particular case, they did a subcutaneous ulnar nerve transposition. So this shows us all of the associated signs we see with MCL injury. Let's move on to the LCL, or lateral collateral ligamentous complex. Let's do a little bit of anatomy here. It is composed of the annular ligament, which is this sort of cup-shaped ligament which cradles the head of the radius and attaches it on both sides to the ulna. There's the radial collateral ligament proper, which goes from the lateral epicondyle and attaches to the annular ligament. And then there's this important structure called the lateral ulnar collateral ligament. Pretty confusing in terms of the nomenclature. That's this thing here, okay? You're going to find it posteriorly on your coronal images, and it's this band here, which is going to come behind the radial head and neck, and eventually it's going to come down and insert here on the supinator crest of the ulna. That lateral ulnar collateral ligament, there's been a lot of literature lately saying that this is thought to be the primary restraint to varus stress. So it's a very important structure. It was on the medial side, we had the anterior band of the anterior bundle. On this side, we have the lateral ulnar collateral ligament. Deficiency of this structure is now felt to be the key to recurrent elbow instability. There's something called posterolateral rotatory instability, which you guys can read about, but is beyond the scope of this lecture here. So what's the mechanism of lateral collateral ligamentous injury? You can have prior elbow dislocation with the posterior laterally directed force. Sometimes when the surgeons go in to debride lateral epicondylitis, they can be a little over-aggressive, and they have gotten into the lateral collateral ligamentous complex and actually disrupted it. What does it look like? It's usually going to be high signal intensity proximally where it originates. You'll see it here on this fluid-sensitive sequence very nicely. It's fairly intuitive. You're going to see focal disruption in that area. Here on this gradient recalled sequence, in another case here, you just don't see a nice lateral collateral ligament. On the fluid-sensitive sequence, fluid, where you should see the origin of the lateral collateral ligament. Another cause, which we mentioned before, is extension of severe lateral epicondylitis. So if you look at this case here, you have both disruption of the common extensor tendon origin as well as extension of the lateral ligamentous complex, denoted very nicely here on this fluid-sensitive sequence. This, unfortunately, usually does not respond to conservative therapy and will require surgical repair. Let's touch briefly on ulnar nerve compression. I'm not going to go through all of the nerves, but we're just going to talk about the ulnar nerve. This is a mind-boggling depiction here of all of the different points where you can have ulnar compression in the upper arm and at the level of the elbow and the forearm. That's way too complicated for the purposes of this talk. What we are going to address here is compression of the ulnar nerve in the region of the cubital tunnel. And again, I like to do anatomy, so we'll do a little bit of anatomy. The cubital tunnel, the floor, as we said before, is formed by the posterior bundle of the medial collateral ligament as well as the transverse bundle as well. And there is a roof. The proximal roof is this structure here called the cubital tunnel retinaculum, also commonly called Osborne's ligament. And the distal roof here is the flexor carpi ulnaris aponeurosis, sometimes called the arcuate ligament. Of note, there is decreased volume in the cubital tunnel in a position of flexion. Why is that? Because when you flex, you make the roof taut and you buckle the floor of the cubital tunnel. So there's decreased volume there. That's why if any of you have had friends, and I've had several who have ulnar nerve symptoms, what they'll try first in conservative treatment is to splint them temporarily in an extended position and see if it resolves. And oftentimes it does. What about the etiology of ulnar nerve compression? Well, you can have thickening of Osborne's ligament or the cubital tunnel retinaculum. If you have absence, which you can have in 10% of cases, then that ulnar nerve can chronically sublux out of the cubital tunnel and become damaged with ulnar neuropathy. You can have concomitant medial epicondylitis or MCL injury, which I've been stressing, or you can have a space-occupying lesion. And we'll look at this case here on the right. You see this kind of fuzzy amorphous calcification here seen posteriorly in the lateral image. This patient was a polytrauma patient. When we did the MR imaging, you see this heterogeneous globular signal intensity filling the cubital tunnel. There's no space there for the ulnar nerve. And if you look a little more distally, look how enlarged and edematous that ulnar nerve is. So this was compressive neuropathy from heterotopic ossification in the cubital tunnel. Another commonly cited space-occupying lesion is a normal variant known as the anconeus epitrochlearis. I think this is probably a little high. We know that the anconeus is normally a posterolateral structure. If you see a muscle belly sitting posterolateral, you have to try to figure out what that is, and it can be an anconeus epitrochlearis, which can compress the ulnar nerve. If conservative therapy fails, again, you may have a patient present here, as this patient did, with no ulnar nerve in the tunnel, and lo and behold, here it is here in a subcutaneous position, transposed. You may want to get that from your surgeons, that history. In the last few minutes here, I'm going to touch very quickly on some special injuries in the adolescent athlete. We'll start with little leaguer's elbow. This is kind of a wastebasket term. Incorporated under this umbrella of little leaguer's elbow is injury to the medial epicondyle. If you have a very young patient, well, first of all, the common injury here, or the mechanism, is much as what you would have with MCL injury in a more mature pitcher. In a young throwing athlete, before you fuse your apophysis, the valgus stress can result in little leaguer's elbow. So remember, this is a diagram from Greenspan's book. Remember that in a very young patient, if you have a trochlear epiphysis, in the absence of a medial epicondyle epiphysis, there's something wrong there, right? Because you should have the medial epicondyle before you have the trochlea. You may have pulled off the medial epicondyle and pulled it into the joint. More commonly, what you're going to see with these patients is what we call apophysitis. So you'll see widening of the apophysis. You may want to get films of the contralateral side for comparison. If you were to do MRI examination on these patients, you're going to see obvious edema there at the level of the apophysis and the adjoining bony margins. You may see on a gradient recall sequence, which is very nice for seeing, it's a nice physial sequence, you may see both signal hyperintensity and widening of that physis, and that is the MR equivalent of little leaguer's elbow. Let's move on to some things that can occur in the capitellum. I'm going to touch briefly on Panner's disease. Now, Panner's disease falls under that wastebasket of the osteochondroses, right? So this really represents a disordered ossification of the capitellum. You see it in young patients, usually less than 10 years old. And what you may see on imaging is abnormal signal plus or minus some fragmentation in that area. What's important is that the vast majority of these are self-limited, okay? So what you might see is just signal hyperintensity in the capitellum, and lo and behold, if you image him at a later point, that may disappear entirely. This is as opposed to osteochondritis dissecans, or OCD. This is a much more serious injury. This is due to repetitive shear and compression. You'll see this in the adolescent age group most commonly. Gymnasts and throwers are most prone to this type of injury. And depending on the stage of the lesion, the prognosis can be awful for these people. We had a tech when I was working up in Boston whose son was looking at a very promising career as a pitcher. He came in with OCD, and we watched his capitellum basically disintegrate over time. It was really terrible. What it can look like is you can see on MRI here, this area of subchondral signal abnormality and loss of overlying cartilage. You have to look for that fragment if you think that the fragment's gone. So lo and behold, when we look through the joint, you see this thing sitting in the posterior superior recess, and you can see it even nicer on the axial images. So in the last half an hour, I just took you on a little bit of a tour of the elbow, tried to discuss some of the more common pathology. I hope I taught you something, and thank you very much.